So looking at chapter 22, this is going to discuss psychiatric emergencies. So these patients might be experiencing a behavioral crisis or a psychiatric emergency, and this could be the result of several different things. There's a lot of medical conditions that could cause you to experience these same signs and symptoms. It could truly be mental illness. It could be because of substance abuse. It could be because of stress or a variety of other things. So at some point, most people in their life are going to experience some type of emotional crisis, but this does not mean that everybody is going to develop mental illness. So you might see some test questions that ask about that. It is true that you will likely experience some signs and symptoms or, experience this emotional crisis, but that doesn't necessarily mean that every person is going to have or develop mental illness. Don't jump to conclusions about yourself or about your patient. You want to make sure you're doing a thorough assessment, or if you're thinking about yourself, that you're taking a look at the facts here. The most common misconception is that if you're feeling bad or depressed, you must be sick. But that's not really the case. There are many justifiable reasons for a person feeling depressed. Usually that's called for, natural to feel these emotions with major things in your life happening, like divorce or ending of a relationship, loss of a job, death of a relative or friend. And so experiencing these feelings for a period of time following those is normal. Another myth is that all individuals with mental health disorders are dangerous, violent, or unmanageable. So only a small percentage will fall into these categories, and you might be exposed to a higher proportion of those violent patients just because that's why 911 has been called, but that doesn't mean that the majority of people who are depressed or have mental illness are dangerous. Many people believe that all individuals with mental health disorders are dangerous, violent, or unmanageable. Again, we said that is going to be a myth. So communication here is very key. Patients will, if they trust you, de-escalate the situation and calm down. And so speak to them reasonably. Let them know you're here to help. Speak to them calmly. Let them know that you understand what's going on, that you want to understand what's going on. If you don't, that you can sympathize with their situation. You might be able to predict some instances of violence. We talked during communication about how a patient paces or clenches their fist or raises their tone of voice or inflection. And so looking at some of those things can let you know, is the patient becoming more agitated? Behavior is defined as what you can see of a person's response to the environment, so his or her actions. And most of the time, people respond to the environment in reasonable ways. And over time, they might learn to adapt to stress. But sometimes that stress is so great that the normal ways of coping do not work. And that's when a crisis occurs. That's when you start having someone lashing out or behaving erratically. So a behavioral crisis or psychiatric emergency might involve patients who exhibit agitated, violent, or uncooperative behavior, or who are a danger to themselves or others. And so when EMS is called when that behavior has become unacceptable to the patient, the family, or the community, that might be where you find yourself intervening. If an abnormal or disturbing pattern of behavior lasts for a month or more, it is a matter of concern. So again, you might see a test question that asks about that. That is, a month of disturbing behavior is generally where you would begin to become concerned. When a psychiatric emergency arises, the patient may show agitation or violence, or may become a threat to their self or others. Looking at the magnitude of mental health disorders, these are pretty common throughout the United States and affect tens of millions of people each year. So a psychiatric disorder is an illness with psychological or behavioral symptoms that may result in impaired functioning. So that's generally where you get a diagnosis, is when you are no longer able to function normally. And so there are several different types of mental health disorders. One of those is anxiety disorders, and underneath that there are different categories. So generalized anxiety, panic disorder, social and other phobias, post-traumatic stress disorder or PTSD, and obsessive compulsive or OCD. Those are all types of anxiety disorders. The U.S. mental health system provides many levels of assistance, so most psychological disorders can be handled through outpatient visits, going in and talking. Some people do require medication through an outpatient physician, and some patients require hospitalization in specialized psychiatric units. So we'll kind of get into this a little bit more, but that's kind of the difference between psychologists and psychiatrists. A psychologist is someone that you talk to. A psychiatrist is someone that prescribes medication for you. And then inpatient psychiatric units would be more like rehab and different places like that. And some can be short stays. Doesn't necessarily mean that you have to stay there for a long period of time. Psychiatric disorders have many underlying causes, so it could be social or situational stress like divorce or death of a loved one that cause that emotional breakdown. It could be a disease such as schizophrenia. It could be a physical illness like a diabetic emergency. So we talked about that previously, how hypoglycemia can mimic a lot of things, and it can make people experience erratic behavior that they're not really sure what they did or have any memory of that. It could be related to chemical problems like alcohol or drug use, or it could be a biological disturbance like an electrolyte imbalance. The EMT is not responsible for diagnosing that underlying cause of a behavioral crisis or psychiatric emergency. There are two basic categories of diagnosis. That's organic and functional. So organic disorders like organic brain syndrome, this is a temporary or permanent dysfunction of the brain caused by a disturbance in the physical or physiologic functioning of the brain tissue. And things that could cause this would be like a sudden illness, traumatic brain injury, seizure disorders, drug and alcohol abuse, overdose, or withdrawal or disease of the brain. And then a functional disorder, this is where it impairs the bodily functions when the body seems to be structurally normal. So there's no interruption in the pathway there. This is going to be more chemical related. So schizophrenia, anxiety conditions, and depression. So again, not your job to necessarily diagnose it. We can do some things to rule it out, like checking your blood glucose, checking your Untitled, completing that physical patient assessment. But at the end of the day, diagnosis of a true medical condition is not going to be up to the EMT. That's going to be up to doctors over a period of time, most likely in a hospital setting. So the safe approach to a behavioral crisis, you're going to need to stay calm. You're going to use a variety of skill set here. Communication is a huge piece. See how he's getting down on his level. He's speaking calmly, trying to de-escalate any potential violence from the situation, making sure that you're staying safe, that the scene is safe. That could rapidly change, so that you're constantly staying aware of your safety, that you're gauging the patient's response to you and to the environment. Sometimes people just don't vibe, and so if you're having a hard time talking with this patient, try letting your partner talk with them, or maybe a first responder or a law enforcement officer there. It doesn't have to be you. Different people click on different levels, so if the patient's not responding well to you, just back up and let somebody else take a try. We can request any additional resources that we might need early. So if you suspect based off the patient's presentation that you're going to need ALS because the patient might need to be sedated or restrained, and that's just one example, then we definitely will want to call for them as early as possible. Looking at the mechanism of injury or nature of illness, note any medications or substances that may contribute to the complaint or be treatment of a relevant medical condition. So do you see medication bottles that tell you that these prescriptions are for psychiatric disorders? Do you see substance abuse, drug paraphernalia, alcohol bottles? Do you see anything that could indicate the patient is a diabetic? Those types of things on the scene. You want to form your general impression, beginning your assessment as you approach the patient from a safe distance, always making sure that you know how you are going to exit. Usually that's the same way that you came in, but you never want to back yourself into a corner. You want to always have a readily available point of exit for you. Looking at your rapid physical exam and observing the patient, making sure that you're getting a good rapport building with them, that you're gaining their trust, that you're speaking with them, again, in a calm, confident, competent manner, that you're trying to get to the bottom of what's going on today and let them know that, hey, you understand they're upset, but let's just, everybody calm down. Let's talk about what's going on, see what we can do. Make sure that the patient's airway, breathing, and circulation are all good, and then you're going to make your transport decision. Unless the patient is unstable from a medical problem or trauma, this is likely going to be a stay and play where you're going to spend quite some time on scene here. Now, different places will have different protocols in place. Some places have critical incident trained personnel, usually paramedics, that you can call on scene that can help to deal with this behavioral crisis, and then know what kind of resources do you have available. If this is someone who is not going to benefit from going to an emergency department, then likely they're just going to check them out in the emergency room and then put them back out on the street, and they're right back to square one. So really understand what type of resources do you have available to you. Do you have mental health facilities? Are there counselors? Is there someone that can come to the scene and talk to the patient if they're suicidal? So just understanding the varying degrees of available resources. Looking at history taking, you want to investigate the chief complaint, and 3 major areas to consider here are: is the patient's central nervous system functioning properly? Are there any hallucinogens or other drugs or alcohol that are a factor here? And are there any significant life changes, symptoms, or illness that are involved? Is there something that set this off? So we want to get our sample history the best that we can, but if we are not able to get all of that information, just do the best that we can. Again, asking any bystanders, call a family member if you have the patient's phone and their emergency contacts are available. Questions that we want to ask when we're evaluating for a potential mental health disorder, asking, is the patient appropriately answering your questions? Does their behavior seem appropriate? Do they understand what you're saying? Are they withdrawn or detached? Are they using appropriate vocabulary and expressions? Do they seem aggressive or dangerous? Is their memory intact? So again, person, place, time, and event. Does the patient express disordered thoughts, delusions, or hallucinations? We don't ever want to feed into those. So if they say they hear something or see something and ask you if you do, you don't want to just feed into that and say yes, because we don't. That's kind of cruel to let them think that everything is okay with what they're saying. So we do want to keep them calm, but you would just say, no, I don't see that or hear that. With the secondary assessment, we're going to move into their physical exam. So for an unconscious patient, of course, we would do that full body secondary trauma assessment. For a conscious patient, if they don't respond to your questions, then we still might need to physically assess them and take a look at some things. You can tell a lot about a patient based off of their facial expressions, and then also some of their vital signs like blood pressure, pulse rate, respirations. Usually those things will be elevated if the patient is extremely anxious, or sometimes if they have taken some of those toxic substances that we previously talked about. A blank gaze or rapidly moving eyes could mean that there is some type of central nervous system dysfunction. So thinking about 2 neurologic conditions, altered mental status, potential for seizures, things like that. And then also, again, looking at our transport decision here, do you need law enforcement or additional personnel to accompany you for your safety? Do you need to take a patient to a facility that's capable of caring for psychiatric problems? And always by ground. The reason for it being by ground is just simply because if a patient is going to be potentially violent, there's not really room to deal with that type of thing in a helicopter. Never let your guard down. Again, never get backed into a corner. Always have your exit planned. Staying calm. If you do use restraints for the patient, then make sure you have ideally 5 personnel there. And so we'll talk a little bit more about that, but ideally having 5 personnel there, 1 person on each extremity and 1 person at the patient's head to be able to restrain them. We need to be filling out additional paperwork, documenting a reassessment every 5 minutes of their PMS, their pulse, and also their respirations and their mental status. We never want to restrain them when they are face down. It should always be while they're on their back. If we're using interventions like emotional interventions, we should diffuse and control the situation, intervene only as much as it takes to accomplish tasks like getting a blood pressure or checking a glucose or things like that. If you're suspecting that pharmacological restraint or sedation is necessary, request ALS as early as possible. And so remember, like we said, if you are going to physically restrain with those soft restraints, they probably need to be chemically restrained as well. So call for ALS. And then with your communication and documentation, give that receiving hospital advance warning of a psychiatric emergency. Likely they will need security or a sitter to sit with them so that they are under constant supervision. And then document thoroughly everything that happened and very carefully. Again, if restraints were used, you need additional paperwork for that. And that's going to ask you what type of restraints, how were they restrained, why were they restrained, so on and so forth. So I'm going to stop this portion of the video here, and I'll catch you guys in part 2.